It's my pleasure to be here with you all this morning to talk to you about some research that we've done at the University of Michigan. And this research has culminated from over the past 15 years. So I don't have any conflicts of interest with respect to the data that I'm going to be presenting to you today. So the chronic pain condition that I've studied over the past 18 years is called fibromyalgia. Fibromyalgia at first wasn't even considered a real disease. Many physicians thought that fibromyalgia was actually just like a makeup condition, that it wasn't really real. But over the last 15 years, we've been able to show that there are changes in the brain within fibromyalgia patients which predispose these individuals to have chronic pain. It's a very common condition. About 2 to 8% of the individuals in any culture will have this condition. As with many other chronic pain conditions, it's more commonly seen in women than in men. It's about 1.5 to 2 times more prevalent in females than it is in males. In addition to having chronic widespread pain, these individuals also complain of other symptoms: profound sleep disturbances, cognitive problems, fatigue, which is debilitating, anxiety, and also mood disorders like depression. So it's not just pain that these individuals suffer from, they suffer from many other symptoms as well. And as we know in traditional East Asian medicine, individuals can present with a complex pattern of symptoms, and this is the complex pattern that fibromyalgia patients present with. They also have heightened sensory sensitivity to all sensory stimuli. They're more sensitive to sounds, to lights, to smells and odors, as well as to physical touch. So it's almost as if these individuals have an increase in their gain on sensory perception. In 2003, we published an article which showed that not all fibromyalgia patients are the same. So if you look at anxiety, down here, depression, catastrophizing, and then you also look at things like sensory sensitivity, so sensitivity to pressures, you find that there's different types of fibromyalgia patients. For example, type 1. So for example, type 1, which is the red one here, they have very little tenderness, but they have intermediate levels of anxiety and depression. Whereas type 2 here, these individuals have increasing amounts of tenderness, but they have also very high levels of anxiety and depression. Whereas type 3 has the most tenderness, but very little sensitivity. They have very less anxiety and depression. So not all fibromyalgia patients are the same. There's subgroups. And that's probably because we just don't understand the individual pathologies that a specific patient may have. So Mitchell, Max, and Clifford Wolf back in 2001 were by far the first to show that, or to propose that not all chronic pain patients are the same, and maybe we should treat chronic pain patients on an individual level. They said that pain can be generated in multiple ways, in multiple different sites of the body, and that can coexist across diverse disease states. The discovery of targets specific to particular pain mechanisms will soon enable therapy to be targeted specifically at those mechanisms. So we've done a couple of neuroimaging studies to show that different fibromyalgia patients are more likely to respond differentially to pharmacological treatments. The first one, which we showed in 2013, was that fibromyalgia patients that had higher levels of glutamate, an excitatory neurotransmitter, in the insula were more likely to benefit from pregabalin treatment, which reduces glutamate release. Another study, which I'm highlighting on the bottom, shows that we can look at brain functional connectivity patterns. So looking at the connectivity between this insula area and this periaqueductal gray region, this connectivity pattern significantly predicted how well a patient would respond to milnacipran, which is a dual serotonin norepinephrine reuptake inhibitor. So the individuals that had less connectivity, so they had deficient connectivity, were more likely to benefit from the drug. Interestingly, when you look at the placebo, there was no correlation whatsoever, so it seemed to be specific to the drug. Here's another study by David Yarnitsky, which looked at this concept of conditioned pain modulation, which in essence taps into how well someone's own pain-inhibiting mechanisms work. And what he found was that individuals that had deficient CPM or deficient endogenous analgesic systems were more likely to benefit from a drug, duloxetine, which is thought to supplement that deficient pathology. So you can see not all pain patients are the same here. Some individuals have very effective conditioned pain modulation, and they don't benefit so much from the drug at all. So this brings us to acupuncture. Could this happen in acupuncture as well? And this article by Lundberg and Lund, which came out in 2007, specifically showed that. They proposed that fibromyalgia patients might be more sensitive or less sensitive to experimental stimuli. And they thought that fibromyalgia patients that are more sensitive to needling might actually not get benefit from the needling. They may actually get worse, whereas individuals that have less sensitivity might benefit from more stronger needling. So this is what was proposed in 2007. And the data that I'm going to show to you today is largely a corroboration of this hypothesis. Namely, individual sensory sensitivities may influence responsiveness to acupuncture as well as sham acupuncture treatment. Today I'm going to be talking about acupuncture at tender points, as well as acupuncture at acupuncture-specific points, as well as using acupuncture needles. This is a slide that Dr. Hélène Langevin, the director of the National Center for Complementary and Integrative Health, thought it would be important to describe these things before giving this talk. So I'm going to be talking about acupuncture needling at acupuncture points, and I'm also going to be talking about sham needling as well. So we did a clinical trial in 50 fibromyalgia patients that were randomized to receive either Verum acupuncture, which is acupuncture at specific acupuncture points, and the points are listed here: Du 20, ear shin min, large intestine 11, large intestine 4, gallbladder 34, stomach 36, spleen 6, and liver 3. That was the Verum acupuncture group. Those that were randomized to sham acupuncture received acupuncture on non-meridians, and it was a non-skin penetrating acupuncture. It was basically just pricking the skin to make them feel like they got acupuncture needling, but in essence, it was a sham treatment. It wasn't a real acupuncture treatment. So the individuals had 9 sessions of treatment over the course of a month, and at baseline, we did pressure pain sensitivity to see if individuals were more or less sensitive to pressure pain, and if that engendered a differential response to acupuncture treatment. This is the mechanism by which we assessed pain sensitivity. What you can see is the individual's hand with their thumb in a chamber, and you can see the chamber right here. So this is the chamber where they put the thumb. And then there's this plunger which descends upon the thumb with a significant amount of pressure, enough to cause pain. And it descends on the thumb when you place weights on this movable platform. And then what I'm plotting over here on the right is the pain scale, which we gave them to rate their pain sensitivity. And so the scale goes from 0 for no pain sensitivity all the way up to 20, which is above extremely intense pain. So for a given pressure stimulus of 2 kilograms, some individuals may report pain as between 7 and an 8, and lower, and those individuals we called low pain sensitive. They weren't very sensitive to pressure pain, whereas individuals that were above 7.5 were labeled as high pain sensitive. They were more sensitive to pressure pain stimuli. When you look to see how these individuals responded to acupuncture, there was quite a strong difference between the Verum and the sham acupuncture groups. Specifically, when we looked at low pain sensitivity versus high pain sensitivity. So for example, here I'm plotting, in this column I'm plotting the low pain sensitive group, and in this column I'm plotting the high pain sensitive group, and you can see these are different clinical pain rating scores. So this is looking at the difference. So for example, in this cell here, we're looking at a 6.9 point drop in the short form of the Miguel Pain Questionnaire in the low pain sensitive group, which is very similar to the high pain sensitive group. However, if you look in the sham treated arm, there's much fewer people responding. There's a much reduced response in the low pain sensitive group as compared to the high pain sensitive group. So for some reason, it looks like those individuals that aren't very sensitive to experimental pressures are less likely to benefit from sham acupuncture treatment. And this is the same data, just presented in a graphical way in a bar plot. You can see in the Verum acupuncture group, the low and high pain sensitive individuals respond essentially equally to the treatment. Whereas in the sham acupuncture group, the individuals that have low pain sensitivity don't respond so well as compared to those that have the high pain sensitivity. This is one of the first studies which we've seen which seems to show a differential response between Verum and Sham acupuncture, where the sham acupuncture arm seemed to be driving the effect. So we wanted to see if this is true in other data sets. Luckily, we had a clinical trial that was done in 2005 when I was at Georgetown University, which was in the same class of individuals. These were fibromyalgia patients. And we randomized them to 1 to 4 different treatment groups. This was a 2x2 factorial design where we simultaneously manipulated correct and incorrect needle location with correct or incorrect manipulation. So there were 4 groups. One group got correct needling with correct stimulation. Another group got correct needling with incorrect stimulation. They didn't get manipulation. The third group got sham locations with correct needling, and the fourth group got sham locations with no manual manipulation. These individuals were then treated once a week for 3 weeks, followed by twice a week for 3 weeks, and then finally for 3 times a week for 3 weeks. And this was the result that we initially published. And this was this was initially depressing for us because it didn't seem to show any specific effect of acupuncture point location or acupuncture needling. As you can see, if you plot the number of responders on the y-axis versus time here, once a week, twice a week, and then 3 times a week, you can see that there's not really any strong trend for any one treatment group to outperform the other. However, in this analysis, we aren't looking at pain sensitivity. We aren't looking at pressure pain sensitivity specifically, which is what we wanted to see in our replication. We wanted to see if patients' responsiveness to either Verum or Sham acupuncture could be predicted by using pressure pain thresholds at baseline. And then we also wanted to look at needling sensations to see if acupuncture needling sensations played a specific role in how well individuals responded. This was what was proposed by Lundberg and Lund, as I was talking about in the beginning of the talk. So remember, we have 4 groups, so we had to simplify the design somewhat so that we could compare it with the more recent study. So what we chose to do was to collapse the groups along acupuncture point locations. So remember, there were 2 groups that got correct location. One of them just didn't get manipulation. We combined those 2. And then the sham groups that had the incorrect needle locations, those 2 groups were collapsed. Remember, half of those individuals got manipulation, whereas the other half didn't get manual manipulation. So those were our 2 Verum and sham groups. And we ended up having 40 in the Verum group and 33 in the sham group after completing the analysis. So now I'm going to walk through the results with you so that you can see what the needling sensation and the pressure pain sensitivity seem to predict. So what I'm going to be plotting here on the y-axis here, up here, is simply the clinical pain that a patient has. Each one of these squares you can think of as an individual patient with a specific type of phenotype, specific type of behavioral characteristic. So these are all the sham group. This is all sham treatment, whereas this is all Verum treatment. And you can see on the upper axis, this is increasing needling sensitivity. So as you go from the left to the right, you're looking at individuals that are more sensitive to the needling. So what you can see right off the bat is that the sham group and the Verum group are dramatically different. You can see in the sham group, as you go from this line, which shows some benefit of acupuncture to sham acupuncture, versus this line, which shows an increased responsiveness to sham acupuncture, that those two are much different. So this looks like individuals that are more sensitive to the needling are more likely to benefit from sham acupuncture, which was exactly what we had proposed in our first paper. So this is a replication of that. But what was remarkable was when we looked at the Verum acupuncture group, that's looking at this over to the right, you can see these individuals show some benefit of the Verum acupuncture, but like when you go all the way over to this side where they have pain sensitivity, increased pain sensitivity to needling, they actually get more pain with needling rather than less. So this suggests that with the Verum acupuncture group, the more sensitive they are to the strong needling, the less analgesic benefit they're going to get. And then you can see this across all the different degrees of tenderness. And again, you can see a dramatic difference between the sham acupuncture group and the Verum acupuncture group, showing that these two treatments are quite different, even when you just look at their pain sensitivity at baseline as a predictor of how well they respond. Looking at it in another way, if we wanted to plot how much pain an individual had at the end of the study based on their pain threshold at baseline, you can see the individuals that received Verum acupuncture that had low pain thresholds, so these would be individuals that are highly pain sensitive. Those individuals that were highly pain sensitive had a score of 57 on the visual analog scale, whereas those that had a high pain threshold, so those would be individuals that were not very pain sensitive, had a much lower pain. They were 44.9, so 57 versus 44, so quite a big difference. And see, that difference is flipped when you look at the sham group. In the sham group, the individuals that are less sensitive to pain actually don't benefit as much as the individuals that are more sensitive to needling and more sensitive to pain. So these findings have consequences for clinical trials. So you all may have heard of the GERAC trials and the studies that were done in the UK and Germany, which found that chronic pain treatment with acupuncture had a marginal benefit over sham acupuncture. It was statistically significant. There is a statistically significant improvement in clinical pain with acupuncture compared to Verum, but with sham acupuncture compared to Verum, but that benefit requires you to randomize a large number of individuals to the study because the treatment effect size is so small. So for example, in the musculoskeletal conditions, it required 7,000 individuals to be randomized to the trial to show a significant difference between Verum and sham. For headache, that was 3,900. For osteoarthritis, it was 1,968. However, if you use pressure pain sensitivity at baseline and were to rerun a clinical trial in a chronic pain condition like fibromyalgia, instead of needing thousands and thousands and thousands of patients to be enlisted in your trial, you really would only need to have 280 to be randomized to show a significant difference between Verum and sham acupuncture. So that's encouraging. That means that if we target our treatment to the right patients at the right time, then our clinical trials don't have to have so many individuals in them. They don't have to be so burdensome and costly. I'd like to end by summarizing a few points. Not all chronic pain patients with fibromyalgia have the same pathology. Some of them have more sensitivity, some of them have more depression. We didn't even look at fatigue or cognitive disturbances or sleep, but those symptoms also vary across the population of fibromyalgia patients. And I predict that if we had personalized therapy designed to those symptoms, we might be more accurate in how well we apply our treatments. Fibromyalgia patients with low pain thresholds respond better to sham acupuncture. The ones that are more sensitive respond better to sham treatments. However, patients with high pain thresholds, so those would be individuals that are not very pain sensitive, they actually respond better to strong needling. And that has clinical implications. Both effects are enhanced by dose. The more number of treatments you give, the more analgesic of response you get. And the sham effects seemed also to be enhanced by sensations as well. So this study has some implications for the future. As I was saying, we may not need as many participants in a clinical trial to find the effect size that we need to test Verum and Sham acupuncture if we did simple quantitative sensory testing at baseline. Past studies that have already been performed that have collected these outcomes might be able to be reanalyzed to see if a new analysis incorporating the quantitative sensory testing benefited or helped the analysis. Finally, not all studies show that needling sensations are captured, like all of the German studies, the JERAC trials and such. I don't believe they actually recorded the needling sensations, which I think are really important when we do clinical trials. And I know Dr. Kong has done some of these studies at Harvard and collected needling sensations, and I think that's very important. And finally, one question is, what's the role of the sensory cortex? So typically we think that the sensory cortex is just responding to an external stimulus, but here it looks like how sensitive someone is actually plays out in how well they respond to a treatment. So the sensory cortex isn't just passively listening and responding to an external stimulus, it's actually playing an active role in a patient's recovery and modulation of pain. And then finally, as Mitchell Max and Clifford Wolf had said in the beginning, practitioners may be able to better treat patients based on more personalized outcomes that are tailored to the specific patient. So that's a concept known as personalized therapy. So personalized pain management, I believe, is the wave of the future, and I think it is something that we'll see more and more of as we keep going. I'd like to highlight the members of the team, so I wasn't doing this work in isolation. I've been very fortunate to be a member of the Chronic Pain and Fatigue Research Center at the University of Michigan. And our director, Dr. Dan Claw, has been a leading expert in fibromyalgia, and he's been a great mentor, and I've really enjoyed working with him. I'd like to highlight Steve Hart. Here's a picture of Steve. Steve has pioneered the quantitative sensory testing. That's the pressure sensitivity on the thumb. So he's pioneered some of that work at the University of Michigan that we've been doing. And then finally, Noah Zucker was a medical student in our group who worked with us for a couple years to reanalyze that clinical trial that we had done in Georgetown to try to replicate the finding that we had in 2013. I've also been very fortunate to receive funding from the National Institutes of Health, as well as the Department of Defense, and as well as a foundation award from the Dana Foundation. And I'd like to end by saying thank you very much for listening, and if you have any questions, I'd be more than happy to try to answer any questions that you might have. Thank you very much.